Assalamualaikum and good morning everyone. I'm Asyiekeen. Today I'm going to present topic about atrial fibrillation lah. One of tachyarrhythmia. What is the definition of atrial fibrillation? It's actually a supraventricular tachyarrhythmia with uncoordinated atrial activation causing ineffective atrial contraction. Also respond in irregular ventricular response lah. So from the ECG, this case is usually found in ED. The most common tachyarrhythmia lah that we can find in ED, especially in elderly. So for the ECG, usually will show absent P wave, or we can see it but not clearly. Meaning there's absence of atrial depolarization by SA node. And also the irregular ventricular response will show the irregular RR interval. So this is the difference between the normal ECG and also the atrial fibrillation. The above one is normal ECG showing sinus rhythm, and the below one showing atrial fibrillation that shows irregular RR interval and there is no P wave. So back to the classification of arrhythmia, there is bradyarrhythmia and also tachyarrhythmia. And tachyarrhythmia can be classified into narrow complex and broad complex, and AF is below the narrow complex. Narrow complex also can be divided into two, which is the regular and irregular rhythm, and atrial fibrillation is under irregular rhythm. So this is the classification of atrial fibrillation. It can be paroxysmal, persistent, permanent, and lone AF. Paroxysmal usually self-limiting AF, generally lasts less than 7 days lah and may be recurrent. And persistent AF, which fails to self-terminate and lasted more than 7 days. Permanent AF is a chronic AF which lasts more than 1 year and cardioversion has not been attempted or failed. And lone AF is AF that presented without such structural heart disease lah. So the pathophysiology of AF is because there is abnormal conduction of the heart, where there is spontaneous discharge of ectopic pacemaker cells in large pulmonary veins lah. And there is multiple waves of electrical activity compete with each other in the atrium and bombarded AV node. For example, when there is structural abnormality of heart, for example, there is enlargement of atrium, there will be irregular and multiple electrical impulses in the heart that will show as irregular pulse lah in the ECG. So the causes of AF can be cardiac causes and non-cardiac causes. These cardiac causes usually will cause structural abnormality or emboli in the heart that cause the fibrillation. For example, in the myocardial infarction, where the heart, in myocardial infarction, for example, there is emboli that can cause impulse, multiple impulse in the heart, and inflammation like pericarditis and myocarditis can cause structural abnormality. Valvular disease can cause embolism, emboli, cardiomyopathy, and others are like cardiac tumors, atrial septal defect, or pulmonary. For the non-cardiac causes, the most common that we can find in ED is like thyrotoxicosis lah, the hypothyroidism, alcohol consumption, pulmonary embolism, and many more lah. So, clinical features that...
Before that, we go to the causes. So causes just now you mentioned cardiac and non-cardiac cause. So most of the time, okay, for cardiac cause, usually is valvular heart disease, patient with ischemic heart disease, patients with long-standing hypertension, where you get LVH. There's also enlargement of your atrium. So these are the risk factors of developing atrial fibrillation.
Okay.
The other thing that you have to take note is in actually ED, okay, we deal with a lot of patients with sepsis. Okay, sepsis, infection, that also is one of the common cause of AF. Okay, let's say if you have a patient with urosepsis, with CAP, all this also can cause AF. Okay, so it's not only thyroid, hyperthyroidism, it's not only the non-cardiac causes of AF. Okay, we also have, we have to think of sepsis as one of the cause of AF.
Okay,
Continue with your clinical features.
Okay, next we go to clinical features of AF. These are like palpitation, patient come with dyspnea, we see the BP, hypotension, patient may develop syncope, fatigue, heart failure and pulmonary edema. On examination, we can elicit irregular pulse, irregular jugular venous pulsation, variation in loudness of S1. Then, if patient come with these features, we'll straight do ECG, right? And after we see ECG showing atrial fibrillation, we can proceed to management lah. Initial management of atrial fibrillation like ABCD. First, we maintain the pattern airway, assist breathing if necessary, and give oxygen as indicated. And put patient on continuous cardiac monitoring and monitor the blood pressure.
Okay, you go back to the clinical features. Clinical features just now. Okay. So just now, okay, first, if you see a patient, you take the history. Then you proceed with your clinical examination. So once when you detect patient have AF, then from your clinical features, you try to find out why is the patient having AF? What is the cause of the AF in this patient? Okay, then once you know patient have AF, you look for the complications of AF. Okay, for the patient. So from history wise, you can see, okay, one, you actually mentioned about actually syncope. Okay, that is one of uh, the possible causes, okay, of a syncope, okay. Then the other thing, you from the clinical features, you see, you have to find out whether patient is in failure or not. The patient with ischemic heart disease, with AF, you want to know is the patient in failure or not. So that's why you look, you auscultate the lungs, look for the JVP, look for fetal edema, and also so on. Okay. Then also
Okay.
don't forget to examine the neck for goiter. Okay. With hyperthyroidism, okay, all that. So these are the things that you have to look for in your clinical features. So you have to correlate between your history and your physical examination. Okay, can continue.
Good. So, patient, after we diagnose patient with AF, first we see whether it's a acute or chronic AF. For example, if it's acute AF, we need to see whether the patient is hemodynamically stable or not stable. Like if he's unstable, like low BP, has heart failure symptom, syncope ke, we need to cardiovert the patient. However, if the patient is chronic and unstable, we will not go straight to cardioversion lah. We will first control the rate of the arrhythmia. So this algorithm is the above one showed about the acute management, the atrial fibrillation, which is acute onset. First, if the patient is unstable, we straight go to synchronized cardioversion. This way, I will explain in the next slide. And if the patient is stable, we will go for pharmacological agents that can control the rate of the arrhythmia. Okay, if we decide to synchronize cardiovert the patient, what actually synchronous cardioversion will do to the patient is it involves delivery of low energy shock, which is time synchronized to be delivered at specific point in QRS complex.
Okay.
So we
Nishikean, before we go to the cardioversion, just now you actually mentioned, okay, synchronous cardioversion for unstable patient. Okay, how you know the patient is unstable?
patient in
Signs and symptoms here.
patient in shock,
Okay.
BP low, heart failure symptom like pulmonary edema ke, kita nampak macam patient in angina, chest pain.
Okay, bagus.
Kalau patient datang dengan sinkop,
Okay.
kita cardiovert.
Okay. Dia basically is any patient which is hemodynamically unstable. Okay, patient who is in shock. Okay, so for you to remember, it's easy to look from head to toe. So you look at the patient. Okay, patient can be confused, drowsy, appears pale. Okay, patient can have diaphoresis and sweating. Okay. Then when you ask the patient complain of having chest pain, SOB. Okay, patient appears tachycardic. Then only you take your vital signs. So vital signs you see BP is hypotensive, SpO2 saturation is not good. Patient is then after that dia punya lungs ada palpitation. Then when you feel dia punya pulse, weak pulse volume, cold periphery. So semua ni adalah symptoms, signs and symptoms of shock. So patient with AF in shock, you have to synchronize cardioversion. Proceed with synchronous cardioversion. Okay. So these are the things you have to recognize. So you cannot delay. You cannot delay treatment for patient yang unstable. Okay, can proceed now with your how to do the synchronous cardioversion.
Okay. We have to synchronize our shock with the R wave in the QRS complex. So we have to do it with cardiac monitoring, and the vulnerability wave has to be avoided. Prior to procedure, we have to properly sedate the patient because the procedure is painful, especially when the GCS of patient is full lah. And emergency equipment should be ready, like suction, back mask in case we need ventilation or intubation. It can be given up to 3 attempts. We can start at 120 to 150 joules and increase in increment.
Is there a maximum? Just now you mentioned 3 times. Is it really 3 times? Can you do more? Can you cardiovert the patient more than 3 times? Boleh tak?
As far as I know yang 3 kali lah doktor.
Dia actually tak ada maximum. Dia tak ada minimum, tak ada maximum. You can still continue. Tapi after multiple attempts of synchronous cardioversion and patient still not reverted to sinus rhythm, then you must think of your reversible causes. And if you read your ACLS algorithm, you have your reversible causes, your 5H and your 5Ts. So you must think of that. You have to look, because if you don't treat the cause of the AF, you don't correct, then patient, the AF will persist. Okay, will persist despite your multiple attempts of your cardioversion. Okay.
Okay.
So you can start with 120 joules, okay, then you can increase up to. Okay, there's no maximum. Okay, it's up. It depends on the machine. What's the maximum voltage that the machine can give? Okay, the amount of joules. Okay. So let's say if you fail synchronous cardioversion, then you can proceed with your chemical cardioversion. This is when the time that you need to give your medication your drugs. Okay.
Okay.
Boleh continue.
Okay. There is certain contraindication, not contraindication lah, certain condition that we suggest not to cardiovert lah. When patient has minimal symptom, multiple comorbidities and poor overall prognosis, especially in elderly patient and paroxysmal AF, which is less than 48 hours. AF that has been continuous for more than 1 year, like the chronic AF, and marked left atrium enlargement more than 5 cm. And the AF that we suspect causes by underlying causes like thyrotoxicosis and pericarditis.
Okay, all of this is only relative contraindication. Dia bukan absolute. Okay, so you have to see because it's quite difficult to determine whether is it paroxysmal AF or not. Susah kan? Tak tahu. How long patient ada AF. Okay. Then after that AF for more than 1 year. Okay, why they say AF more than 1 year not to convert?
Maybe patient dah ada medication before this.
Okay. Then okay lah, dia tak semestinya. Okay, because we do have patients with chronic AF. But then suddenly if they come, their heart rate sampai 150, 160, they are in shock. And instead of shock patient having chest pain, you still can proceed with cardiovascular. Semua ni. All the list that you mentioned here still can proceed with cardiovascular if patient is unstable. Tapi for thyrotoxicosis, you must treat with medication at the same time. Because if you don't give the medication, then patient will still have persistent AF.
Okay.
Okay?
Okay.
You can continue.
Then we go to the chemical agent that we can use in AF. Most commonly used in our ED is amiodarone and digoxin. First, amiodarone is a membrane stabilizing anti-arrhythmic drug that can increase the duration of action potential and refractory period in atrial and ventricular myocardium. Usually, we will use amiodarone in patients with poor ventricular function. We can use amiodarone whether we have failed cardiovascular or in a stable tachyarrhythmias. How to prepare is to dilute 20 ml of amiodarone to dilute amiodarone in 20 ml with 5 solution. We can give in unstable patient 150 to 300 milligram over 10 minutes. And for stable patient, we can give 150 mg IV over 20 to 1 hour. The maintenance can be 900 milligram IV over 24 hours. But we have to be careful because the side effect of amiodarone is hypotension and bradycardia and heart block. Therefore, we have to monitor patient the vital signs and also put on cardiac monitoring. Next, digoxin. Digoxin is actually a cardiac glycoside. Usually, we will use digoxin when we suspect patient with heart failure. Digoxin also can improve the cardiac contractility. We can give loading dose 0.5 milligram in 50 cc normal saline over 20 minutes. The adverse effect of digoxin is digoxin toxicity, heart block and bradycardia. So patient yang macam AF dah lama diagnose and on digoxin, kita macam mana kata?
So if patient is already on digoxin, you have to be cautious lah.
Because of
kalau dia cakap dia baru saja makan digoxin pagi tu, then maybe you can give a lower dose. You tak payah bagi loading lah. Give a lower dose or you can consider to give amiodarone instead of giving digoxin. Sebab digoxin dia ada narrow therapeutic index. Kan, kalau dia senang, you give extra nanti boleh overdose. Okay.
So this is the management if patient come with unstable AF. Then after we stabilize the AF, usually we will refer patient to medical, right? If it's the firstly diagnosed. This is actually management cascade for patient with AF. Hello?
Boleh dengar?
Boleh dengar tu?
Boleh.
First, we see the presentation and any associated disease like DM, hypertension, ischemic heart disease. This is basically the initial assessment, and we assess the risk of stroke and actually bleed risk. Okay, this one based on Chapter score and Hasbet score. Because patient with AF, we anticipate risk of stroke in the future. However, if we want to start the anticoagulation like warfarin, patient need to come for regular follow-up and have to be compliant to medication. Therefore, we also have to assess the risk of bleeding. Like we have to really ask the patient whether he or she can come for follow-up, compliant to follow-up to medication. If the patient is old and more prone to fall, like usually fall, we usually not start the anticoagulant lah, because it will lead to risk of bleeding. Okay, the management, the general principle.
Now, okay, regarding your anticoagulation, usually this one they will start in the ward lah. Okay, normally this one we won't commence in the ED. Okay, actually you have to calculate based on the Chapter score, Hasbet score. These are the two main scoring systems which you use prior to starting the patients on your anticoagulant. Kan, just now you mentioned regarding warfarin kan. Selain daripada warfarin, is there any other anticoagulant that you know person can use?
Aspirin.
No, I'm anticoagulant.
Heparin.
What's more common? Kalau korang kat medical, mesti commonly. Rarely dah orang bagi patient on warfarin nowadays. Oral anticoagulant for patient AF. Yang clue dia tak perlu monitor INR. Lepas tu dia mahal lah.
Oh, dabigatran.
Yeah, correct.
More and more patient AF is on benda-benda macam dabigatran dan sebagainya. So
actually ada banyak all of this is your NOAX lah, your new oral anticoagulant. You have your apisaban, rivarosaban, okay, and also dabigatran. Tapi I think medical here they give, but it's limited lah. They have a quota. Because this one is expensive lah. Okay. Tapi the benefit is patient tak payah nak come for routine blood investigation, tak perlu check your
the key thing about long-term anticoagulation for patient with AF ni, you need to balance the risk versus benefit lah. The risk of bleeding versus the benefit protection against stroke. Itu je the reason why you want to long-term anticoagulate the people with AF ni, is because they have a higher risk of developing stroke lah, thromboembolic stroke. So you want to anticoagulate them, tapi you need to balance between their risk of bleeding dengan their risk of having stroke. If their risk of bleeding is higher, macam yang Asyiekeen cakap tadi, dia selalu jatuh, tak mai follow up, tak patuh kepada pantang larang kan. Macam warfarin kan, there's a lot of pantang larang kan. A lot of things that you can eat, you cannot eat. A lot of drugs that interact with warfarin. So if your patient has higher risk of bleeding because dia tak comply dengan pantang larang, dia selalu jatuh, nobody to bring him or her to follow up, then the lower risk is let them face the risk of getting a stroke lah, rather than facing the higher risk of bleeding. So it's not straightforward lah benda ni. You have to assess patient by patient. Tapi this is mainly nanti bila korang kat medical, kat klinik medical dan benda-benda macam tu lah. So not all AF automatic start anticoagulation. You need to justify lah sebenarnya.
Okay, tu.
Okay, continue.
Okay, first, these are the management general principle, especially in the chronic AF lah. And first, the rhythm control. We want to revert to sinus rhythm, followed by maintenance of normal sinus rhythm. And rate control, administration of medication to control the ventricular rate. and to prevent the systemic and thromboembolism with anticoagulation. Like I said just now, the choice of treatment is depend on clinical presentation, whether the AF is proximal, persistent or permanent. Urgent cardioversion is usually indicated in patient with short or severe hypertension, pulmonary edema, MI or ongoing myocardial ischemia. So the management, the integrated ABC pathway. A, just now we talk about anticoagulation and to avoid stroke. B, better symptom management. After medical, seeing the patient in what medication that will better their symptom, and also the cardiovascular and comorbidity optimization. So B, for the better symptom control, we can discharge patient with beta blockers if the patient is not in heart failure. And for AF in older patient, usually we will discharge patient with digoxin. And for the rhythm control, we can use cardioversion. And this is more advanced lah, like catheter ablation and surgery for AF MACE procedure. And C, cardiovascular and comorbidity optimization. We advise patient for weight loss if patient is obese, reduce alcohol consumption, and doing more physical activity. And cardiovascular risk and also comorbidities like the hypertension have to control, have to monitor their BP and also the sugar level. Patient in heart failure, coronary artery disease and sleep apnea. These are like comorbidities usually found with AF lah. That's all for me.
Okay, got any questions from the audience? Ada soalan tak? Ni Dr. Farus nak tanya soalan.
Tak ada. Cukuplah soalan Dr. Rafeek.
Okay lah, Asyiekeen lah. Okay, Asyiekeen, thank you.
Okay, thank you very much.
Apa ni Syami kan?